Welcome to the Greater St. Louis MGMA's June 2022 webinar. Before we get started, we have a couple of quick housekeeping items. All webinar attendees will be in a listen-only mode. The chat feature will be used to take any questions, so please feel free to submit your questions at any time during the presentation by clicking on the chat icon at the bottom of your screen. Questions will be addressed at the end of the speaker's formal remarks. Today's webinar is being recorded, and a copy of the recording and any available slides will be posted on our website under the online education section of your member center once you log in. Thank you again for joining us for the June 2022 webinar entitled Good Faith Estimates, Understanding, Compliance, and Solutions, presented by Andrew Hardy and Allison Plummer of Rivet Health. I am now going to turn the controls over to our speakers.
Awesome, thanks so much, and thanks everyone for being here with us today. As we get going, talking about No Surprises Act and good faith estimates, there is obviously the audio component, but we do have a screen share as well. So if you're just dialed in via phone or audio only, definitely recommend hopping in so you can see the slides. There's hopefully a lot of good content in there and some nice good pictures to keep things fun and light. So kind of learning objectives for today. Hopefully by the end of this session, you'll have a better understanding of what the No Surprises Act entails and glean some advice on how to stay compliant. So keyword on advice, and we'll go through the old fancy legal disclaimer here in a minute. But a quick introduction on who you are going to be listening to. Who you're going to be listening to today. There we are. So my name is Andrew. I'm the Vice President of Customer Success here at Rivet Health. So I've been in revenue cycle my entire career, both in a consulting and operational standpoint. And then my counterpart is Allison Plummer.
Hi, thanks, Andrew. I'm the Estimate Product Specialist here at Rivet Health. I have been in healthcare for about 25 years, mostly in revenue cycle, but have worked extensively in the trenches, I'm going to say, like in practices, in many capacities, I guess.
Yeah. She downplays her level of expertise, but I'll try and pump her up a little bit. So from an agenda standpoint, pretty brief agenda, but a lot of content in each of these sections. We're going to talk an overview of what is the No Surprises Act. So this has been a rapidly evolving kind of maybe understanding of requirements from CMS and how those are going to be enforced and regulated. And then talk about some balance billing. And then a component that we're going to go a little further into detail is what's called the good faith estimate. So creating those, how to stay compliant, certain factors that need to be included in the good faith estimate. And then one thing that we're seeing kind of crop up a little bit more and more as of late has been the different dispute resolution processes. So both from a provider standpoint, what your options are, as well as things to be aware of if your patient initiates a dispute process. So we'll go through a few different sectors there from a dispute resolution. And then here's that legal disclaimer I alluded to a moment ago. Neither Allison nor I are attorneys, and if there's a formal sign-off in compliance that you are seeking, definitely recommend reaching out to if you have a legal team or a compliance team, kind of make the proposal for the solutions around, this is our intention around the No Surprises Act and good faith estimates. Do you believe we're in compliance? Our goal today is to kind of hopefully give you an understanding of what it would take to get to that level of generally accepted compliance and kind of put you on the right trajectory there. So with that, let's dive in. And then throughout this, if there are specific questions that you may have, there is a chat function. Feel free to post a chat in your questions. If at any point in time you say, hey, related to this specific component, there's just a public chat, and I'll type in something right there just to show you where it all kind of pops up. That's just a test question. Allison and I will keep an eye on that chat feed throughout the webinar today. So if there's something particularly pertinent to a slide, we'll try and observe that and pause and address that. If not, we've got plenty of time saved at the end of the presentation to answer any and all questions, at least to the best of our abilities. So Very cool. Well, let's hop in and talk about what the No Surprises Act is. So by a rhetorical raise of hands, anyone recognize that individual in the top right-hand corner? His name is Mr. Bill Gates. So with that, the goal of No Surprises Act is no surprise bills. So kind of like that little image there. But the main purpose of the No Surprises Act is really to protect those individuals from receiving surprise medical bills. And there's a few different components of what might kind of constitute a surprise bill, right? We'll go through a few different slides around emergency services. There's a big push on in versus out of network providers and how both reimbursement is going to differ and the ability or really just the legality of balance billing between in and out of network providers and residual balances for patients. And then there are some components, I think most of you all, if you're at an MGMA webinar, are probably on the professional or physician side of things. So you're likely not billing a ton of transport or air ambulance providers, but you may know that those are really, really high dollar services. And in many cases, because of the level of trauma or transport associated with air ambulance, oftentimes the patient will have, if they're even coherent enough to have a conversation, they're in some very risky situation that they'll need to have air transport in the first place, but there are protections around air ambulance providers. And then on the right-hand side there, we also, as mentioned just a few slides ago, starting to initiate different dispute resolution processes. So it outlines between the payer and provider. So now with accepting different levels of reimbursement for out-of-network procedures, you now have a different level of reimbursement that you can possibly dispute back to the payer and say, hey, this is why I need to be seeking additional reimbursement for this. And then between the uninsured or self-pay individuals and the residual bill that they owe, those are outlined by the good faith estimates that we'll talk about later on in the presentation. But there is a dispute process around when that estimate is plus or minus really just over $400 different than what the original good faith estimate entails. There is a dispute process. So that's a quick high-level overview of the No Surprises Act. And then I'm going to kick it over to Allison to talk about that first bullet there in some depth around emergency services for out-of-network providers.
Thanks, Andrew. So one of the regulations is that emergency providers cannot balance bill patients that have group or individual health insurance who receive emergency treatment for a payment amount greater than the in-network rate for those services. And there's really kind of not an exception to this rule. They're specifically referring to services that would be provided prior to medical stabilization. So the patient's not really in a situation where they could opt into paying a residual balance. So non-PAR providers and non-PAR facilities cannot balance bill patients. So with that, just like everything else, there's a lot of exceptions to the rule. If post-stabilization, if the patient is stable enough to travel to an in-network provider, but chooses not to, then they can be balance billed if the provider provides the patient with the appropriate notice and consent. And the caveat down there is this is totally different from the good faith estimate. On the CMS website, there's a 4-page form that the Department of Health and Human Services has provided and requires. The patient essentially has to sign that they understand that their bill is going to be materially higher than if they went to an in-network facility, and they're fine with it and they accept the balance bill. There, thanks. Okay, so this is kind of, I think, the thing that's going to happen more often. Services performed from out-of-network providers at in-network facilities. Example, you go to the hospital to have something done. The hospital's in your network. Maybe your surgeon's in your network. Maybe it's an emergency, but the anesthesiologist is out of network. Or you're in your in-network hospital and they call in an on-call specialist, and the on-call specialist is out of network. So Same idea. They cannot, especially in emergencies, they cannot balance bill because you're not in a situation where you can accept it. The only way they can balance bill is if notice and consent was given ahead of time. So this is something everyone needs to be doing. All providers, it says in the law, all providers must disclose to all patients information regarding federal and state balance billing protections and how to report violations. The quote from the law says, providers and facilities must post this information prominently at the location of the facility, post it on their website, and provide it to the patient, beneficiary, or enrollee. So what that says to me is a poster in the office needs to explain to patients that they have protections against balance billing. And then when they're signing their, I would think the easiest time would be when they're signing their HIPAA consent kind of a thing. They need to be given a notice of these protections also. And I'll hand it back to Andrew.
Yeah, so transitioning from just the kind of general No Surprises Act into a little bit more tactical good faith estimates. So this has been something not only because of the No Surprises Act and requirement around good faith estimates, but just the shift in patient mindset from, hey, I'm just a patient within healthcare, to this consumer mindset where I'm like literally shopping for healthcare, or I'm comparing multiple diagnostic imaging centers, or I've got the choice to go to a hospital for a surgery or an ASC for a surgery. We've seen just estimates in general pick up throughout the healthcare industry because patients want to have that transparency. They want to have the financial discussion, or at least a financial understanding. And then now we're seeing legislation, both at the federal and certain states are starting to roll out their own pricing transparency requirements. And the good faith estimates is one of the first pieces around that's coming from the federal level. So good faith estimates is really focused towards your self-pay and uninsured patients. Traditionally, if you think about healthcare in general, the self-pay patient is one of the leading causes of bad debt. It's the highest residual balances because there's no insurance to offset these residual patient liabilities. And so the good faith estimates outlines, again, all providers, as Allison mentioned, for the No Surprises Act. Same with GFEs, all providers, regardless if you are a doctor, a physician, a hospital, an ASC, an imaging center, everyone must provide a good faith estimate for the expected charges to any self-pay or uninsured patient. So we'll go through in a few slides the scope of all the data that's needed to be in compliance with a good, solid, good faith estimate. But first up is talking about some of the process. And so this is the timeline that's been released from CMS and HHS around how quickly or rapidly after services are scheduled do you have to provide a good faith estimate. So looking at that top slide there are for not necessarily add-ons, but they are fairly quick happening services. So within 3 to 9 business days before the date the item of service are rendered. So you basically have plus or minus a few days, but a week until that scheduled appointment. Then your goal as a group should be to push those out no more than 1 business day after the patient is scheduled. And so that, you think about it from a process standpoint, like your scheduling and registration team is probably working anywhere from 3 to 4 days out to maybe 7 to 10 days out on their schedule. And so that goes right in line with if a patient's appointment is scheduled for 7, 8, 9 days out, well, they have to turn things around, from a good faith estimate standpoint, the very next business day. Anything that's scheduled further out than that, so at least 10 business days, so kind of 2 business weeks there, then you have 3 business days after the original date of scheduling. So that it's at least thoughtful that CMS did not make everything 1 business day, because that would pretty much be unrealistic for everyone to be turning things around the very next business day, when most of the time your team might not even be financially clearing that patient or checking for insurance or going through all the pre-registration steps until maybe 7 days in advance. So the 10 days, if you have more than 2 business weeks, you definitely have a longer lead time. And then if the self-pay patient actually requests a good faith estimate, again, you are expected to turn that around as a provider group, to turn that request around within 3 business days as well. And so this is what we've been seeing more and more interesting, especially for maybe elective or shoppable services. So imaging procedures are the big ones, right? You can go on, you can see how much is an MRI going to cost me. Patients are becoming a little bit more consumer minded, especially with the increase in deductibles, right? We have seen $3,000, $4,000, $5,000 deductibles be fairly common, that patients are saying, hey, it's September or November, I'm not going to hit my deductible anyways. I might as well shop this out and see what the cheapest price can be. So even though they might have insurance, they're opting out of insurance and treating themselves as self-pay because they might be able to find cheaper prices by being a self-pay patient for your practice. So that's one that we've seen patients beginning to actually request their own good faith estimates. So that's a timing of things, and thinking through, just a couple questions to probe. No answers needed, but feel free to kind of chime in on the chats with anything that you've started to roll out at your group. Is how you think about, right? Historically, even if they're self-pay, the statement, it's generally coming 1 to 2 months, 4 to 6 to 8 weeks after the original date of service. So they might be going through insurance and you drop a residual bill. You might have to go through the coding and charge entry process to even know what the CPT codes or HCPCS codes that are being rendered for those patients are. So one kind of challenge to the group is, how are you going to move something that typically happens post-service, all the coding and charge entry, up into the kind of front end of the revenue cycle, and think, well, how are we going to know what procedures are going to be done for the patient? Is it a surgical procedure? Great. You probably have some component of an order, referral, or pre-visit that's coming. It says this is coming for a knee replacement or a hip or some arthroscopic procedure. When that's the case, that lends itself well to creating an estimate because generally what type of procedure is going to be rendered. Same thing with maybe coming in for office visits, E&M codes, right? You might not know if it's a level 2, level 3, level 4 new or established patient visit, but that generally the difference in charges for those 2s, 3s, and 4s on the E&M code are going to be within that threshold for the good faith estimate for residual billing that we'll talk about here in a little bit, of being anything more than $400 is a big enough deviation from the estimate itself that it could trigger a dispute process. So that's one of the biggest challenges we've heard from groups is like, well, how do I know what the patient's coming in for? How do I create an estimate when they haven't been seen by the physician yet? And that is a challenge that you're going to have to kind of face as your group's thinking about the good faith estimates. Is at what point do we receive a CPT or HCPCS code level procedure that we can put on the good faith estimate? So that's definitely one of the big challenges we've seen from a timing standpoint. So that translates nicely into kind of the scope of what is going to be on a good faith estimate. So this is just a basic bullet list of items that are going to be found on the good faith estimate. So as you'd expect, the patient name and date of birth, those are basically your patient identifiers, right? Most patients don't know their MRN or account ID if from ECW or NextGen or Allscripts or Athena. They don't know what their patient account number is. They know their name and date of birth. So that's a good identifier. The next couple around not only the CPT code, right? 99213, 67228 if you're ophthalmology, 27130 if you're orthopedics. Not only the actual CPT or HCPCS code, but a description. So they kind of use loose language on plain English. So patients do not know what CPT codes are or what HCPCS codes are, or what J codes are. They know what a knee replacement is or an MRI of the shoulder is. So that's where it's really geared towards being a patient-friendly estimate, is helping them understand, hey, this is the actual billing code, but here's really what it is. And then something that might be fairly new, especially for the physician world, where most of your contracts and fee schedules are not structured such that you're getting paid off of ICD-10 or diagnosis codes. Most of your fee schedules are still CPT or HCPCS code based. And so including the primary diagnosis on the good faith estimate is something that might just be a new, maybe a new paradigm, is associating the CPT codes with procedure codes. But from a data standpoint, it shouldn't be new because the 1,500 that you're billing out is going to have those ICD-10 codes on them anyways. Then we get into some of the financials, so the expected charges. And the charges can be somewhat loosely defined because we work with practices that their charge master or the billed price for the practice is actually the same as the self-pay fee schedule. And then we also work with practices that have a different self-pay fee schedule. So the definition of the expected charges is going to be what you would bill the patient for that procedure, whether it's a self-pay fee schedule that's maybe less than the charge master or billed price, or you're actually just moving the charge price and saying there's no adjustments because you're just a self-pay patient. So the expected charges are what you would be dropping to the patient from a patient responsibility standpoint. And then from some practice identifiers. So the names of providers and facilities, and I mentally asterisk this one a little bit because Allison will talk about co-providers here in a few slides. But the names of your providers and facilities, so Dr. John or Jane Smith, and they're coming into this organization or this practice. And then one thing that I'm still surprised is a requirement of the good faith estimates, but your group's tax ID. And the reason I say I'm actually surprised by that is you can do a lot with tax IDs. If you have the tax ID, you can oftentimes call payers and ask for a contract, and all they ask for is the tax ID. So I am kind of surprised that that's included on there, but from identifying a group or practice, definitely helpful. And then the NPI or National Provider Identifier. So these, if you're not familiar with what tax IDs and NPIs, NPI is going to be present for all of your providers. It's what you use to enroll them they have a taxonomy that's associated with an NPI, and it's managed through the NPPES data registry. So the NPI is something that all of your providers should typically have, as that's also an element from the claim. And then right here we have estimates for any services that might be provided in conjunction. So this is definitely a new mindset of ancillary services. So how many times, if you're a specialty group and you're coming in for an outpatient surgery, oftentimes you're going to have, there's likely an anesthesiology bill, or maybe there's a supply charge. Maybe somebody bills for the DME component of a knee replacement different than the primary surgeon. These are called ancillary services and typically found under lab work, hospital or OR, or anesthesia are some of the most common. But this has a little pin on it until next year, until 2023, just because I think, once again, it shows a little bit of knowledge that they actually think about, hey, no practices right now share cost information. How do you balance this in a paradigm where nobody knows what the lab is going to cost or the anesthesiologist is going to bill because it's probably a different entity or different billing group? So those are some of the components on a good faith estimate. I want to just show you, kind of how we've structured these things. So this is just a screenshot example of an estimate coming out of Rivet. And you can see just the number of purple arrows pointing to different data elements. There's a lot that goes into this estimate. There's, and one thing notorious for healthcare is statements are confusing. Patient statements are difficult. They've got a bunch of charges, adjustments, claim adjustment reason codes, remark codes, patient deductibles, coinsurance, right? There's a lot that goes into a statement to be transparent with the patient, but they don't understand a lot of that. So maybe some concerns with the level or the volume of data that is required on a good faith estimate might be that you're overwhelming the patient to the point that they don't even know what they're looking at. And so trying to, whether you use a program for this, or we'll talk about in a moment, there's a CMS example. They provide a form for a good faith estimate. Try and be as clear cut and concise as possible so the patient doesn't get overwhelmed, so that they fully understand what their residual patient liability is going to be for that specific encounter. So this is an example of what rivets look like. Here's an example of the CMS one. So this is available online. You can hop over to cms.gov and download this. It's a very long form, multiple page PDF, but they do give it to you in, if you're familiar with a PDF that can be clicked through, they do give it to you in a nice, fairly efficient way to input. But again, it's a lot of data entry, patient demographics, diagnosis codes, procedures, providers. But this is a free form that's available on CMS.gov. So that can be helpful from at least downloading that to think about in revenue cycle, how are we going to start to piece together all of this data? And so you can use this as an outline. And then one thing that is very specific with good faith estimates is starting to think through disclaimers. So again, I think back here you see, again, it's probably very small or very fuzzy on your screen, but we've got this disclaimer here that's a good faith estimate compliant disclaimer, but they outline some key components to that. So things that in the disclaimer itself on the page of the estimate stating that it is a good faith estimate and it is subject to change. Now, the reason, or at least I believe or interpret the reason they say to include that subject to change is this is new. You as providers historically have not quoted patients' costs up front. And so you're doing your best to pull together what are the procedures, what's being done. But we know what happens. Sometimes they come in for a level 3 and they get bumped up to a level 4 because of more acute questions. They come in for a certain type of surgery and you open them up and realize that something else has to be done, right? Things do change. And so stating that it is subject to change is not a end-all be-all bill. This is not the only cost you will ever see. It is just an estimate. And then there may be additional items or services that points to it's possible that when a encounter is happening, that you actually have to do something different that you didn't plan or estimate before. Something about the patient-provider dispute resolution. So Allison will talk a little bit more about this here in a few slides, but if the residual bill for a patient is higher than $400 more than the original estimate, the patient has the ability to file a dispute practice or a dispute process. So stating what they have the ability to file that dispute and then how they can initiate that. Is it a phone call? Do they have to go through a website? Is there an individual or email that they can initiate that through? Be transparent around how they can initiate this process. And then once again, just reiterating, the good faith estimate is not a contract. So those are all the components from a compliance standpoint that go into the good faith estimate. One thing that is not being enforced, loosely not being enforced right now, but is tentatively planning here in 6 or 7 months, is going to be co-providers. So again, this is a very neat but radical new paradigm around, hey, I'm a patient and I'm receiving an estimate from my physician office, but I'm expecting several different bills, right? One from maybe the anesthesiologist, one from the OR or ASC. And so co-providers are going to be pretty new. And Allison will talk about some of the co-provider piece here and then a few components of like the checklist for the good faith estimates.
Okay, you kind of teed up my co-provider thing. When I talk to practices, this is one of the things they're most concerned about, especially if you're a specialty practice that maybe you're a surgery practice and you do things at a facility. Okay, so there's 2 different words we have here. One is the convening provider. The convening provider is the term they use. It's going to be the provider that's scheduling the service. If you're a surgeon, the surgeon is going to be the convening provider. They are scheduling the service at a facility. Co-provider in that circumstance would be the hospital, lab if they bill separate from the hospital, and the anesthesiology group if they bill separately from the hospital. The premise to this whole thing is, and what I think the intent of the bill was, that self-pay patients don't get surprised. We've all been to the doctor, if you've had a baby or gone and had a surgery and you think, oh, certainly the bills are done, and they're not. There's like the person who read your x-ray sends you a bill. And I think the intent is that the patient, when they come in and they get their good faith estimate, they're going to see entirely what they would owe from the surgeon, what they're going to owe from the facility, anesthesiologist, radiologist, whomever is going to participate in their care. The convening provider would be responsible for gathering all of those other estimates and getting it back to the patient. You can see why when I talk to practices and consult on this is one of the number one things that comes up. Nobody has this infrastructure in place. Nobody's ready for it. Nobody has a system in place. Nobody has a way it's going to happen. This came out in the original bill and is still in there. And it has said, the intent says, Department of Health and Human Services will enforce this at their discretion. And what everyone kind of takes that to mean is they're not going to start enforcing it until 2023. Unfortunately for all of us, it's halfway through the year almost. And so we need to be thinking ahead. Maybe things are in such flux in healthcare, and particularly in this No Surprises Act. Maybe they'll punt it for another year. Maybe someone will bring a lawsuit and say we're not ready for this, and they'll push it off. But as of today, it is still in the bill and will be required starting in January. So convening provider would then, you have no later than 1 business day after scheduling the appointment to contact and reach out to co-providers. And then they have, I think, 1 business day to turn around their co-provider estimate, get it back to you so that you can then give it all over to the patient. Let's see. Oh, and a little asterisk at the end. The Department of Health and Human Services encourages including a range of expected charges for items or services expected to be provided and billed. So you don't have to be as exact as you think, and I think it protects everyone if you kind of give them a range, because then you're less likely to be outside of that $400.
And one thing that's pretty new around co-providers and co-facilities is how do you even interact with these things? So one thing that we've been working on here at Rivet is giving you a way to create your own estimate and then basically create a cover sheet on that estimate that you can quickly send over to any of those co-providers or co-facilities. So whether it's fax, whether it's email, whether some physician groups that we've seen are, they're on campus with different hospitals or ASCs. However you communicate that back to those co-providers and co-facilities is try and make it as easy as possible for that co-provider to give you that information back in a concise method.
Okay, so after all this information, it's kind of overwhelming, but here's like a basic good faith estimate to-do list. Number 1, post the notice. We talked about posting a notice for balance billing. There is also a notice that you are supposed to post in your office, on your website, in languages spoken by your patients, that the patient has a right to receive a good faith estimate of expected charges. It's listed on the CMS site. You can just go download it. So that's number 1, post that. Number 2, when patients call to schedule, they need to be asked. Ask patients, are you covered by health insurance? And do you plan on using it? If the patient has insurance, and they're going to use their insurance, you don't need to worry about it. If they are self-pay or they've chosen, so in some way they've chosen not to use their insurance, then that needs to go into like your separate workflow to get a good faith estimate. So then you need to tell the self-pay patient that they have a right to request a good faith estimate upon scheduling, or if they just request it. Next step, provide the good faith estimate to the self-pay patient who asks about costs or requests a good faith estimate. You need to ensure the good faith estimate is complete and accurate and includes all of the required elements and disclaimers, because the patient will be eligible to initiate the patient-provider dispute process for incomplete or inaccurate good faith estimates. So it is imperative to provide new and more accurate good faith estimates if changes are made to planned care before services are rendered. Basically saying, if something materially changes between what you've estimated that their costs are going to be, I come from spine, so you thought they were going to have a discectomy, then upon further looking at the imaging, they're going to need a multi-level fusion. I would for sure do a new good faith estimate. Provide the good faith estimate on paper or electronically, depending on the patient's preference and within the set timeframes established by the No Surprises Act. A lot of the practices I consult with are providing them electronically just purely because you have this 1 to 3 day deadline to get this to the patient, and there's not really, unless the patient's going to come in or is sitting in front of you, there's not a better way to get the estimate to the patient. So some of the other less exciting features of the No Surprises Act, we've kind of just thrown on one slide here. There is a provision for continuity of care. If your provider belongs to a network and then chooses to leave that network, they have to provide continuity of care for their network patients. That involves informing all of their patients on that network that, Dr. Smith is no longer with the network. And Dr. Smith needs to continue to provide care for those patients for 90 days or until the patients find another provider in the network. And then the last piece of it is providers are responsible now for keeping their directory information updated with the insurance companies. Oh, still me. Okay. The dispute resolution processes. These are really not terribly fun, and they're kind of in flux. Not so much with the patient-provider one, but there's been a lot of lawsuits and litigation around the payer-provider dispute process. Okay, this is the patient-provider dispute process. If the actual charges are $400 or more than the good faith estimate, the patient may initiate the patient-provider dispute process. They have to do it within 120 days of receiving the bill. To initiate, the patient will submit their notice plus the administrative fee to the dispute resolution entity. The dispute resolution entity will notify the providers and request information or documentation from the provider. Providers have 10 days to submit the required information. During that time, the provider cannot have the patient's bill go into collections. So once the patient's initiated the dispute, you need to stop all collection process from that patient. The dispute resolution entity will make a decision within 30 days. The loser of the dispute will pay for the dispute resolution process entity fees. On the CMS website, there's more examples of this. I have customers ask me all the time, what should we do when we told the patient it was going to be this, the doctor got in during whatever procedure, and it's so much more? Patient or the care just became more complicated. They found something inside, kind of a thing. So what it says on the CMS website is just documentation. Make sure you have documented, took patient to surgery for discectomy, came in, found that it was this, ended up doing this. That all has to be documented in your op reports, in your office notes. And then if the patient opened a dispute process, you would then submit all of your documentation proving, because this is really common and it's going to happen all of the time. So just make sure that you're keeping your documentation. This is the worst one. This is the one that's really in flux. This is the federal independent dispute resolution process between payers and providers. This goes back to the balance billing. So when this bill came out, the initial thing said providers must accept in-network rates. And providers have been very upset about that. And there's several, the AMA filed a lawsuit. There's lawsuits in Texas regarding this, where providers are disputing that. And they're saying that's not fair. We shouldn't have to just accept the in-network rate. And it's kind of in flux right now. I know that in Texas, the judge has ruled for the providers in the initial preliminary hearing, but we don't know yet if the federal government is going to appeal that. But this is basically how it goes. So the start is the furnished or covered series, the service happens, and then the payment or denial is sent by the payer to the provider. And then if the provider is unhappy with the payment amount that they got from the payer, they can open a negotiation period. And it must be initiated within 30 business days, beginning on the day the out-of-network provider receives either the initial payment or the notice of denial. So they have this open negotiation period. The parties must exhaust a 30 business day open negotiation period before either of them can initiate this federal IDR process. So this slide is really weighty. You can initiate the IDR process. And it says either party can initiate the federal IDR process by submitting a notice of IDR initiation to the other party and to the departments within 4 business days after the close of the open negotiation period. Basically during this, you get it started, then you guys have to pick an entity to arbitrate your claim. You have to both submit what you think is a fair rate. So the federal government comes up with what they think is the payer comes up with what they think is a fair rate. The provider comes up with what they think is a fair rate. And it's called baseball style arbitration. The arbitrator is not allowed to come up with something that meets in the middle. The arbitrator is forced to pick either the provider's suggestion or the payer's suggestion. And according to the AMA, the reason they did this is because they want to encourage both parties to come forward with like maybe their best offer. Not if either one is being, way out there kind of ridiculous, their offer is not going to get picked. So that's essentially what it is. There's so many laws around it, and the process is really in flux with the litigation around it. Okay, so because we were speaking to you guys in Missouri, the other thing that complicates this even more is some states have the state involved in this federal process, and Missouri is one of them. If you go to the federal website, it says Missouri has a bifurcated process where sometimes the federal government is involved and sometimes the state is involved. So we threw this slide in here for you. Special to Missouri, this is the arbitration process for out-of-network care at in-network facilities for balance billing. So there's a separate arbitration process for unanticipated care at out-of-network care at in-network facilities. Providers will send the charges to the patient's healthcare carrier within 180 days. The health carrier has 45 processing days after receiving the claim to pay the provider a, quote, reasonable reimbursement. If the provider declines the healthcare's initial reimbursement offer, the provider and health carrier enter a 60-day good faith negotiation period. And if not resolved by the end of the negotiation period, the provider or health carrier needs to initiate the arbitration process through written notification within 120 days of the end of the negotiation period. So similar to...
We're going to, in order to do this, and this is what my complaint was initially, we're going to have to sign, this is going to be somebody's freaking job.
Yeah, probably. It's so complicated for providers to dispute. They've made it so cumbersome, and the deadlines are tight. The Missouri one, your deadlines are a lot bigger, 45 days, 120 days, 180 days, but the federal process, the deadlines are really fast.
Cool. And then kind of the last one we have here is starting to identify remittances or adjudicated insurance claims that have specifics around the No Surprises Billing Act. So this is an extract. If you're all familiar with the x12.org, it's where the source of both claim adjustment reason codes and remittance advice remark codes that come back on EOBs or 835 remits. So there's about 21 new remark codes for claims and line items that are specific to the No Surprises Act. So you can see a lot of these, Missouri, you're not in a all-payer model, but some of them specifically mention the all-payer model agreement from a reimbursement standpoint. A lot of them talk about here's, for example, Allison was just talking about a non-participating at a participating place or facility. So there's a lot of new remark codes. And then there are some new ones that I find specifically interesting, like N878. So I'll just read this verbatim, but the provider or facility specified that notice was provided and consent to balance bill obtained, but notice and consent was not provided and obtained in a manner consistent with applicable federal law. Thus, cost sharing and the total amount paid have been calculated based on requirements under the No Surprises Act, and balance billing is prohibited. So there are some remark codes that permit any residual billing, because you've indicated, very similar to the older advanced beneficiary notice or ABN, right? When you have the ability to residual bill a denied CMS claim. This is that same type of thing, is notifying that they have been notified of any residual bills. But then there's this N878 explicitly prohibits any balance billing for this specific procedure. Then there are also some of these remark codes that outline that this is how adjudication or the reimbursement rate was set. It also outlines some components of disputes. So what is this one? Is this something that you can dispute? And here are the process to dispute that with the payer. So these new adjudication remark codes from the 835 remits or EOBs, these are something you should start keeping an eye on for if you have a claims analytics system. Like, for example, at Rivet, you can put a filter in for any remark codes and say how many claims or remits show this remark code on them. If you have a mechanism like that, that's going to be really helpful to start identifying how many things are coming back with No Surprises Act remark codes involved in those in the adjudication process, because the remark code itself has some further description around what you can and cannot do and how that reimbursement was set. So some helpful things that we started seeing, you see the effective date for all of these new remark codes here in the little italics right below the remark code. All these are now effective March 1st, 2022. So we expect more and more commercial or Medicare Advantage payers to begin including these on some of their adjudicated claims. So that is kind of all the upfront content that we had produced. Starting to hop into any questions.
Yeah, okay, so I saw someone ask this question, and the reason I want to address it is because I've gotten this question so many times, specifically about cosmetic surgery. So cash pay cosmetic surgery. If you go to the American Society of Plastic Surgeons, they also address it, and really the federal bill says, all medical services, all providers, all patients. I understand it's easy to think, well, we're just cash pay, it's just plastic surgery, but it's not exempt from the good faith estimate requirement. The good part about it is really when you're doing cosmetic surgery, like what you tell them it is, what it is, that's the bill. So the chances of them opening a patient-provider dispute are pretty much zero. But according to the law, and that's all I'll say, according to the law, cosmetic surgery is not exempt from the good faith estimate requirement.
And especially on some of those cosmetic procedures, I mean, whether it's some of the cosmetic injections or reconstructives, they can be really high dollar things. And collecting, you're probably very familiar with collecting from patients upfront pre-service for that. But having a mechanism to justify outline the costs and whether you're using formal CPT codes, right? I think part of the question was, we just give them a description of what the service is. That's putting in as best you can a type of code and the description. Again, at the end of the day, it comes down to documentation. Are you covering your bases by, it is good faith, and it is good faith on the provider side, and doing your best to outline what's being done, what's being rendered, as well as what the associated cost is really what it comes down to. I think we've got answers to a lot of the questions that have already been submitted. Maybe what other, to dentists, eye doctors, podiatrists. Okay, there we go. A few questions coming in. Does it apply to dentists, eye doctors, podiatrists? I cannot speak to the dental piece. I know that we have ophthalmology and podiatry practices on Rivet's platform that are using it for good faith estimates. So I'm not sure about the optometry component of eye doctors, but I do know from an ophthalmology standpoint, then yes, your ophthalmologist would fall under this, as would your podiatrists. Next question, we have a portal where patients can enter the service they're having and their insurance and get an estimate online. Do we have to provide one?
I think if it meets the requirements, it has, according to the federal law, it has to have those components that we listed on it. If the portal does, then I think that is delivering a good faith estimate to the patient.
As long as it has many of the components that we talked about a few slides ago in it. And I believe we mentioned that this will be shared, both the recording and any relevant slides. So you can observe that checklist and maybe create one from that portal and be like, do we need to add a few additional data or criteria elements into that online or portal-based estimate so that it is in compliance?
The next question we have is, how can you do injections in advance for cosmetic patients? They're assessed upon arrival, what they need. We cannot quote those in advance. I think you can either provide a range of what services might cost. I think it's just kind of doing your best to let patients know ahead of time what the costs might be. but things can change when they come in. The same thing happens if, say, a patient's coming and they coming in for an office visit. You're going to let them know ahead of time, oh, it's just an, what we think, just this office visit. And then they get there, they need an x-ray, they need a brace, they need all of these other things. That's to be expected. And I think you just keep up your documentation that, like, ahead of time, we didn't know they needed this. And then when they got there, they did. And it just comes down to your documentation.
Sweet. Here's a handful. We can share the actual URLs or links behind these if interested. There's more and more documentation and collateral being released on a weekly basis as legislation is coming out that clarifies some maybe vague components on the initial release. But also just more research is being done around how can we be compliant, what's the minimally viable solution to this so that we're in compliance without upheaving our entire revenue cycle process. We're happy to share these resources and encourage you all to be proactive about looking at does your practice management system already have something? If it doesn't, and you don't already have something existing, are there vendors in the market like Rivet that would help you be compliant on this? And then kind of third is thinking internally with your own practice is operationally from a process standpoint, how do you roll this out? How do you move things that are historically on the back end of revenue cycle, like charge entry, coding, claim submission with diagnosis codes? How do you take that from post-encounter, post-visit into pre-service so that you can create these estimates? And even thinking not necessarily just the No Surprises Act and good faith estimates, but just in general, one increasing pain point for a lot of practices has just been the increasing deductibles, slower patients to pay, the amount of bad debt that gets written off, the amount of adjustments or courtesy adjustments that get written off for patient residual balances, third-party collections. All that's really expensive and high cost, right? You render a service, it goes to bad debt. You've now paid the provider for the service, you've paid for the supplies, and you're getting paid nothing in return. So outside of just the good faith estimates, you're going to be doing the legwork to have that mechanism in place to create a good faith estimate and think about how you can roll that out to other patients to kind of address the consumerism in healthcare and hopefully collect more from your patients pre-service or at point of service to reduce your AR, reduce the amount of patient bad debt that gets written off. And by being compliant with the good faith estimates, you also have opened up a world of opportunity to accelerate your patient payments. So I'll kind of close it with that. And if you have any follow-on questions, this is my email. You can also ping Allison. It's the same domain, but it's just Allison, ALLISON @rivethealth.com. Feel free to reach out to either of us. We'd be happy to connect with you and your groups or share any findings or questions that we may have. So with that, I want to thank you all for spending the last 55 minutes with us, and good best of luck as you roll this out to your group and being compliant and support all of these pretty big administrative changes over the next little while. So thanks all for your time.
Today's webinar, and I would like to thank everyone for attending, and a big thank you to our sponsors, Andrew and Allison, for their informative presentation. And everybody have a great day.